as, of course, degenerative and deformity. With me tonight are two of our star spine-oriented residents. We have Tim, who's our chief resident right now, who's going to be starting a spine fellowship at UCSF starting this summer. And then we have Josh, who's one of our senior residents who's recently completed an infolded spine rotation with our ortho spine department at Maryland, which we have a very good and close working relationship with. So my objective tonight is essentially to talk about some safe techniques for treating thoracic kyphosis with spinal cord compression due to pathologic fractures, primarily from a posterior approach. And there's many different reasons why people can develop a thoracic kyphosis due to fractures. From a pathologic standpoint, we have infections such as osteomyelitis, discitis, and Pott's disease, which is, of course, more common in the developing world. Tumors such as metastatic and primary tumors, osteoporotic fractures, which don't necessarily, aren't necessarily pathologic, but are also play a role here. Especially, I've seen several patients who have had kyphoplasty, and then their fracture worsens, and the bone cement and fracture retropulses into the canal, causing worsening stenosis and cord compression. And then, of course, there's traumatic fractures, which is not the scope of this presentation. So what is the main indication for why we operate on these patients? Obviously, paramount is spinal cord compression and neurologic deficit. And sometimes spinal cord compression, even if they don't have neurologic deficit, if you're worried about something that's unstable or something that has the propensity to worsen over time. Obviously, another indication is the need to treat the offending pathology, such as an infection or a tumor, if the patient is experiencing a progressive deformity, or if they have significant pain that is failing other more conservative treatments. Oftentimes, these patients have severe foraminal stenosis due to the collapse of the offending vertebrae, which causes increased narrowing of the foramen and sometimes bone or tumor in the foramen. And then, of course, non-union patients who have had a fracture for some reason and over time have not healed. But a lot of these things go hand in hand. Non-union often leads to progressive deformity and pain that fails other treatments, et cetera. But these are the main things that we consider. How we can treat this varies, of course, by many different factors. And, we could debate this until we're all blue in the face, but, sometimes it's an anterior only approach or a posterior only approach. Sometimes it requires a combined approach. I put kyphoplasty there for completeness, but it's really not the scope of what we're talking about today, which is really more severe kyphosis and patients who have neurological compromise or spinal cord compression. But certainly for certain circumstances where there is no significant cord compression or neurologic deficit, and the kyphosis is not severe, kyphoplasty is certainly an option. Especially now that we have some newer techniques like the spine jack, which can potentially be used to help restore kyphosis or restore normal vertebral body height. Other things to consider when choosing an operative approach can include things such as patient age, medical comorbidities, bone quality, which is very frequently an issue with these patients, where a lot of the reason why they're here is because they have poor bone quality, and thus leading them to be more susceptible to fracture and kyphosis. And then obviously surgeon experience. My background and training, prepared me to tackle these problems from a mostly posterior only approach, or even accessing the anterior column through a posterior approach. But some people may have more experience with an anterior approach and therefore feel more comfortable performing those procedures. So that's what we're going to talk about today, is more of a posterior only approach for these problems. So what is the goal of surgery for any of these patients? Obviously, the primary goal is going to be to decompress the neural elements, to remove the pressure from the spinal cord to remove the foraminal stenosis and improve their thoracic radicular pain. But that's going to be easily the main goal of any surgery. Another goal is to treat the offending pathology depending on what it is. If it's a tumor, performing a separation operation, removing it from around the spinal cord, debulking as much as you can safely debulk depending on what kind of tumor it is. If it's an infection, clearing the infection if antibiotics aren't able to completely, take effect and treat the infection completely. The third goal would be to stabilize the spine and prevent it from worsening deformity or progressive deformity. And then the last goal would be to correct the deformity itself. And of course, as we mentioned on the last slide, taking into account, age, medical comorbidities, correcting the deformity is probably, while important and can certainly prevent, future failure and morbidity due to poor sagittal balance. It's not as important as some of the other things on this sheet. And, perhaps, the goal should be less aggressive in correcting a significant deformity in an elderly person with poor bone quality compared to a younger person who's relatively healthy, who can tolerate some of these procedures that we need to do in order to correct a significant deformity. From a posterior approach, the main advantages, it's a single precision surgery, for better or for worse, that potentially leads to less OR time, less having to move the patient around. There's less risk to intrathoracic structures such as the lungs and great vessels. You are able to directly decompress the foramen. You're also able to perform, posterior osteotomies from a posterior approach, and you don't need an access surgeon. And of course, there's some spine surgeons out there that may feel comfortable, doing their own approach, transthoracic approach. But I personally don't, so I would use an access surgeon, which of course, just adds more complexity to the case. Main disadvantages to a posterior approach is obviously you need to work around the spinal cord. That's probably the biggest disadvantage and also the biggest risk, because when you're manipulating things around the spinal cord and trying to push fragments that have retropulsed into the canal around from ventral to the spinal cord, you're not necessarily seeing what you're able to do all the time, and it can certainly be risky. Corpectomy is certainly more challenging from a posterior approach, as well as trying to get a large cage in can also be challenging. And then another disadvantage, while it's not that significant, is of course the need to sacrifice thoracic nerve roots, which you may not have to do from an anterior approach. So what do we think about when we're trying to plan for these operations? The first consideration, which I'll show in some graphics on the future slides, is, what do we need to do in order to treat the pathology, which in this case is usually anterior to the spinal cord. It's usually ventral. So there's usually a kyphosis, and either the kyphosis itself is causing a stretching phenomenon of the spinal cord, or it's actually causing pressure on the spinal cord, but it's usually in the front. So what do we need to do in order to treat that? Do we need a transpedicular approach? Do we need to perform a corpectomy? So do we need a larger approach, such as a costovertebral approach or a lateral extracavitary approach? Then what do we need to do in order to treat the deformity? Are Smith-Peterson osteotomies enough versus a PSO versus a vertebral column resection? Do we need to sacrifice a nerve root? And then do we need to consider the artery of Adamkiewicz, which is typically, it technically can be anywhere, but it's typically on the left side from T8 to L1. So if we're operating at those levels, do we only sacrifice the nerve roots on the right side? What are we going to use for bone grafting materials, especially if it's a tumor or an infection and we don't want to harvest autograft? How many levels of instrumentation do we need above and below our construct? 2 levels, 3 levels, more levels? And then does the patient have poor bone quality? Do we need to consider cement augmentation of our screws? Do we need to consider cement vertebroplasty of whatever the pathology is at the level that caused, in addition to our fusion, which I've done for a few select cases. So these are all the things to consider, and every patient is different. And we'll present 3 cases today, and we'll talk a little bit about some of these factors going into those cases. This is just a graphic showing the various approaches from a laminectomy to a transpedicular costotransversectomy and a lateral extracavitary approach. And this is a graphic sort of demonstrating what you can accomplish from that side. Now, I perform, a transpedicular approach very often for various things. And, I find that I can, between doing that and maybe just removing a little bit of the rib head, I can get out a fairly significant amount of the vertebral body, especially if I do it bilaterally. So I very rarely have the need to take, a significant amount of the rib unless I'm trying to put a cage in for various reasons. And then what kind of osteotomies, from a Smith-Peterson osteotomy to a PSO to a modified PSO or vertebral column resection, do you need in order to correct the deformity? So what do we typically do in these cases? We use a Jackson OSI table. We do a lot of, I put my instrumentation in the thoracic spine in using AP fluoroscopy. So a Jackson OSI table is radiolucent and gives us good views for both instrumentation placement as well as localization, which we'll talk about in a minute. We monitor all these patients with SSEPs and motor evoked potentials. And we always get supine baselines so we can see if positioning, because a lot of these patients are unstable for one reason or another, we see if positioning causes any changes. And of course, a lot of these patients who have significant cord compression may not have normal potentials in the supine position. And it's much better to know that than after you've flipped the patient or before or after you've started operating. And then we use a C-arm, sometimes depending on the situation, a robot or navigation. And we always use an ultrasound for every thoracic case. It allows us to see through the spinal cord and tell exactly what's going on. And we have plenty of examples of that coming up. And just ultrasound can also be helpful because it helps you confirm that you're at the appropriate level. Obviously, we use fluoro for that, but once you're actually in there and you perform the laminectomy, it's comforting to use the ultrasound as soon as the laminectomy is done and actually see the fragment that you're worried about pushing on the spinal cord from the front before you start drilling into the pedicles. But it also allows us to ensure that the ventral cord is decompressed, and it also allows us to avoid, or once we do the cord, the deformity correction, and we close the osteotomies, you sometimes see a kinking in the dura, and this allows us to demonstrate that the spinal cord is not being kinked as well, and Tim has a good example of that later. Localization this is the last thing that I'll say, and then we're going to start talking about cases. So localization in the thoracic spine is challenging. Obviously, if you have a fracture or some sort of pathology that you can see on the fluoro image, that's very helpful. Obviously, also if the patient is very kyphotic, the apex of their kyphosis can also be very helpful. I do make sure even if we're not talking about thoracic kyphosis, where we almost always have a CT scan looking at the bone. Any patient, even if it's an arachnoid cyst or something that's getting a thoracic procedure, gets a CT scan so I can count all of the ribs and make sure I understand their thoracic anatomy. And then I either count down from the first rib or I count up from the 12th rib, or both if it's a middle level. And when in doubt, you can use multiple spinal needles and count from L5, S1 for the bottom, but this can still be challenging. And this is an example from my fellowship that I'll never forget. So this was a patient where, if you look and count this, L5, 4, 3, 2, 1, and there's a transverse process there. And we looked on the CT scan and we saw that there were 12 ribs. But we didn't have a good fluoro. This is actually an X-ray, but we didn't have a good fluoro image in the operating room, and we were concerned. So we actually started counting from the side. And this is actually one of our fluoro images from the case. So this is L5S1. So this needle is pointing at the L4-5 disc space. So we started the surgery, it was in the mid-thoracic area. And right before we were about to put our screws in, we realized, counting down from the top, that we were at the wrong level. And the reason we were at the wrong level was because this is L5, not this. So this is actually the L4-5 disc space. And in addition, the patient had a unilateral 12th rib and a transverse process on the other side. So all of our methods, other than counting down from the top, basically all of our methods of assuring that we were at the appropriate level in this patient had failed. But that was certainly an interesting learning experience. So my recommendation there is study all of your preoperative imaging as closely as possible and correlate what you see on the imaging with what you're actually seeing in the patient, and do that every time you're localizing a thoracic level. So we have 3 case presentations. Josh is going to start out, and then Tim, and then I'll go over a very complex case.
All right, thanks, Dr. Crandall. Can everybody hear me?
Yeah.
Okay, great. So our first case here, we have a 74-year-old female who carries a diagnosis of metastatic lung cancer with a known pathologic fracture at T4. She's currently being treated at presentation to the clinic with Keytruda or pembrolizumab 3 times a week. Of note, her previous procedural history is that she actually underwent vertebroplasty at an outside hospital for treatment of this fracture. But over the course of about a year, she had been developing worsening mid-scapular back pain, essentially in that region, to the point where it's become severe and intolerable, as well as some right-sided radicular pain that's in the T4 distribution. Otherwise, she's neurologically intact. So this is a plain view X-ray of her initial presentation, actually just a chest X-ray, the lateral position, where you can see the pathologic fracture at T4 and the previous cement from the vertebroplasty, noting how severe the local kyphotic angle is there at the level of the pathology, about 41 degrees. Further imaging demonstrates this even more. So her CT scan, which you can see kind of the sagittal on the left compared to the MRI as well, shows the amount of vertebroplasty cement and bone that's now protruding into the spinal canal, causing pretty significant spinal cord compression at that level, which you can also see in the axial cuts in both areas. So to tackle this, obviously this is a pretty challenging pathology, especially in the setting of previous cement. So the surgical plan was as follows: initially to plan for a partial T4 corpectomy, the posterior 1/3 of it, which would be accessed through a bilateral T4 transpedicular approach, as well as T3 and T4 posterior column Smith-Pete osteotomies to correct the kyphotic deformity along with that, and then instrumentation from T2 to T6 with a partial laminectomy at T5, and of course with the use of the intraoperative ultrasound, like Dr. Crandall mentioned earlier. And these images are from that ultrasound, which I think show this very nicely. You can see after the laminectomy has been performed, you can appreciate the amount of ventral compression on the spinal cord at T4 from that pathologic fracture. And then after the transpedicular decompression and deformity has been corrected, you can appreciate the spinal cord now looks more relaxed and more harmonious and is not kinked from the correction as well. Post-operative x-rays demonstrate kind of what you see again from the ultrasound, now with a much more harmonious appearing thoracic spine with a local kyphotic angle that has changed now to 29 degrees. So the patient did very well. She followed a pretty uneventful hospital course and was actually discharged day 4 home with home PT and a rolling walker. Following up to today, her back pain essentially has resolved and she's doing very well over 1 year now post-op.
Thanks, Josh. So, this is an interesting case. And I mean, I think it's interesting just because it was made, a little bit more complicated by the fact that she had cement there. So she, developed this kyphosis. She has cord compression. She's not particularly myelopathic, but she has a lot of pain, and she has this, cement here that's causing fairly significant. This MRI really doesn't do it justice. The ultrasound actually does it a little bit more justice, I think, for how bad the cord compression actually was. No real signal change yet, which is probably why she wasn't myelopathic. But it presents a problem because this has already gotten worse. This is going to probably continue to get worse. This was a metastatic tumor, so there's maybe not a lot of tumor yet. I can't recall. I don't think she had gotten radiation yet, right, Josh? She had not gotten radiation yet. She just had the kyphoplasty, and she was treated with the monoclonal antibody. But basically, my goal of the surgery was to correct the deformity, but decompress the spinal cord. So drill away, this area, which we were able to do by just taking down the pedicles at the level below, and obviously the pedicle at the level that's fractured, and performing and removing the facet joints bilaterally. So taking down the pedicles bilaterally, or I guess we didn't have to take the pedicle down at this level, but taking down the pedicles at the offending level, taking down off the facet joints bilaterally at this level and this level, which also would help us with the deformity correction. But then using that to push away. And the ultrasound, I think, is incredibly valuable and helpful, because I can't tell you how many times I've been in the operating room and I feel like I've decompressed everything and I'm able to run a Woodson under there, and it gives me a little bit of a false sense of security because it feels like things are decompressed, but then I get an ultrasound image and there's still some compression. In addition, I'll add that you can actually see, sometimes you might still have a little bit of compression, but then when you close the osteotomy, particularly in a PSO, you can actually see some of these fragments kind of push away once you straighten out the kyphosis as well, because the cord is not draped over the kyphotic segment anymore. Looks like there's a couple of questions.
Yeah, Ken, somebody was asking about the workflow and the ultrasound, and I think Tim answered it, but I think it'd be helpful for you to let the whole audience know, because not everybody checks the chat room. They were talking about what kind of ultrasound,
right?
You use it. And...
So we use the local ultrasound, like Tim mentioned, but I've even used, at an outside hospital that I work at, I've even used, the ultrasound that anesthesia uses to put in lines and just put a sterile drape over it. And then you have to irrigate, into the wound, so you have something for the sound to transmit through. But you can get a decent picture, a useful picture from almost any ultrasound. It's more about the size of the probe. So we have with the local ultrasound, we have like a hockey stick shaped probe, which I think is actually meant for spine. But then we also have a cranial probe, which is helpful as well. And we use it very frequently because it's just right there. It's sitting on the field. So we'll do the laminectomy and then look to see what's going on. Then we'll, get down ventral to the cord, and we'll maybe start taking some out, and then we'll look again, and then we'll look again. We look like, every so often to see what we've done. And then we always look again after we've done, a deformity correction and changed the orientation of the spine.
Ken, what's your strategy for the decompression? Do you try to drill a ventral defect and then push that into the defect rather than the cord?
Yep. So that's exactly what I do. So I drill, and that's why going in from both sides is helpful, because you go in through one side and you drill the ventral defect, and then you get like an Epstein curette or some other instrument and just push it down into the defect that you created. And then you go around the other side and you do that as well. And you can use the Woodson as well, which is a little bit longer, and to get under there, and also try to push as long as you've gotten it pretty shelled out.
Ken,
and someone
the methylmethacrylate there make it any harder, or was it just like peeling down cortical bone?
Makes it literally harder, yes. But yeah, it's a little bit more challenging with the cement there for sure.
Ken, someone asked, why wouldn't a costotransversectomy transversectomy give you better, the shallower angle of coming in? Would that not give you better and safer working conditions?
I mean, it certainly would give you more room, and it would certainly give you potentially a better angle. But I just feel like it's not necessary, at least in my workflow. I don't feel it's necessary for me, at least. But it certainly can give you better angles, and it's certainly necessary if you're going to do, a full corpectomy or get further down into the vertebral body.
One last question. Somebody asked about where did you put your bone graft with such a wide decompression?
You put it up. Well, in this case, if you don't do a costotransversectomy, transversectomy, you still have a little bit of, transverse process. So you span it on the lateral aspects of your rods. And then, the good news is that it's usually not that big of a problem in the thoracic spine that these are failing.
I have a question. So it's Harley from a pen. I have a question regarding your choice of anterior reconstruction. What makes you choose between nothing in the front, where you just get a shortening of the vertebral body, cement, like we do in the old days, so we still do it in some cases, and a cage. So I think the advantage to reconstruct the anterior column with either cement or a cage is when you do correction of the deformity, you don't get any kink of the dura, so you don't have to worry that you have kinked the spinal cord. Now, if you do it, so you're gonna get or shortening, you're gonna get kinked of the dura, and then you worry about the kinking of the spinal cord. So what you take on these three different things? Just a pure vertebral column shortening, injection of cement just to replace the defect, or cage just to prevent a loss of height, and so what's your different strategy between the three?
Yeah, I mean, I think that's something that I think about fairly often. I feel like if the area is already pretty significantly collapsed, then the anterior column is already shortened. And as long as I can take the pressure away from the spinal cord and I can see that it's not being kinked on the ultrasound, then I'm not as concerned. But if it's like a very big, if the whole vertebral body, and in a case that we'll show a little bit later, this is the case, but if the vertebral body is very lytic and it's not that collapsed, then I feel like there's a bigger need for anterior column support. In this case, the patient already had cement within the vertebrae. So that was sort of taken care of. And I have certainly also done that as well, where I've cemented the vertebrae as well. But
and so as you think ultrasound, I've never used ultrasound just doing all this. I've done just probably close to more than 100 definitely of these. I never had any issue with a neurologic compromise, but I make sure that we don't get too much kink of the dura. So do you think we should use the ultrasound as a kind of mandatory? Because if you do a costotransectomy, you see, as a matter of fact, pretty well that there's nothing in the front. You see a decompression. I think it's more helpful in a case like this, where you're not trying to remove the entire vertebrae. You're just trying to remove that bony spike, or some, especially in this case, cement that might be, that you might get everything that's out laterally, but then there's maybe still one little spike right in the middle that you can't completely appreciate. Whether or not it's important to remove everything once you've removed the majority, that's on a case-by-case basis. But in my institution, ultrasound is readily available and free. So the patient doesn't get billed for it, and it's just sitting right there in the corner of the room. So it's very easy to just request it at any time. And it gives me a sense of security.
But whoever's driving, use their pointer and just kind of orient the audience to the anatomy.
So this is essentially a sagittal image. So this is the spinal. So this is the saline that we've irrigated into the wound. This is the dorsal dura. This is the spinal cord here. This is the vertebrae and the bone fragment. This is the echo from the cement that's in the collapsed vertebrae. Here's the disc spaces, and then here's the other vertebrae right there. And then here you're seeing CSF ventral to the spinal cord and no bone touching the spinal cord anymore. And you can, I mean, this is a live image, so you'll see the spinal cord pulsating, up and down within the thecal sac. Just not here.
And Ken, how far away do you hold the probe from the door?
Couple centimeters, but you can set the depth to whatever you want, but a couple centimeters. What's the hardest part in some of these really kyphotic people is that, especially if they're very thin and they don't have a nice deep cavity, sometimes the saline will kind of just run out of the wound and you don't have enough to see. That can sometimes be challenging, but it's not. You can also just put gel on top of the dura too if you really wanted to.
There's a really nice images when you point all the anatomy out to us.
Yeah, thanks. We have a few more. We can get to the next case, and there's a couple, some in that case from a paper that we actually published on it too. So Tim's gonna. Oh, the next slide. Tim's gonna start talking about this case.
Okay. Thanks, Ken.
Yep.
So this is our second case. This was a 68-year-old male presented with severe mid-back pain following an admission for MRSA bacteremia. You can see the T2 and then T1 post-sagittal images on the right there. Prompted a 2-level laminectomy at another hospital for evacuation of an epidural abscess. Unfortunately, by 10 months after his operation, the patient had deteriorated. He'd essentially lost the ability to stand, lost the ability to walk, and he presented with urinary retention to our clinic, to Dr. Crandall's clinic. And he also reported almost complete absence of sensation in his legs. Go to the next slide. So you can see here the interval imaging was performed. This MRI was actually several months before presenting to our clinic. You can see the development of a pretty severe kyphosis with retropulsion of a infected disc osteophyte complex with associated T2 cord signal change on the right. Keep going and go. And this was our exam. He had a sensory level. He could, really only walk 1 to 2 feet with assistance. He was diffusely weak in his legs, spastic, with some clonus in his legs. So we brought the patient to the operating room. You can see intra-op fluoro shot as well as an immediate post-op X-ray. For this patient, we performed instrumented fusion from T4 to T11, as well as laminectomy at T9, bilateral transpedicular decompression at T8, Peterson osteotomies at T6 and T8, and then also a 3-column pedicle subtraction osteotomy at T7. We also, as Dr. Crandall mentioned, we use continuous SSEP and motor evoked potential monitorings as well as the intraoperative ultrasound. One of the important things to note about this case is during the decompression, we actually lost reliable motor evoked potentials in the lower extremities during the case. And so this brings us to this. We just wanted to mention, Dr. Crandall alluded, we did publish this small case series last year, really describing our experience with ultrasound. I don't think we have any ultrasound images of this particular case, but this kind of illustrates it. We continue to have SSEPs were reliable, and what we were able to do was really to bring in the ultrasound and really interrogate the actual morphology of the cord, and everything looked fine. There was no ventral kinking. There was no dorsal kinking. Everything looked very good. So that gave us the confidence to proceed with the operation. You can just see here that what Ken was mentioning. This was a patient. This was actually after PSO osteotomy was done. And you can see before and after reduction. You can see it's a little small, but in figure B there's a small black arrow. It's pointing to a region of kinking of the thecal sac. This is very common when performing this reduction. And then you can see a corresponding ultrasound image there. You can see nicely the kinking of the thecal sac, but of course, the question is, what does that mean for the underlying cord? And you can see here that the morphology looks quite nice. And again, this is just another case. This was done before the osteotomy, just demonstrating clearing out of some space ventrally for the cord, basically giving it room in the front, again, to allow us to safely feel confident that we're safely performing the reduction thereafter. And then this again is just a summary in the red arrow there, just demonstrating ventral disc osteophyte complex. Could be any kind of ventral mass, and then as well on the blue arrow there, the dorsal dura. So in following with our patient here, he was improved. He came back to see Dr. Crandall in his clinic, reported significant improvement in his back pain, his ability to walk, and is now able to get around his house, still with assistance, but notably improved. And just a final images here. You can see this is July 21. This was just before he presented to our clinic. You can see a pretty pronounced kyphotic deformity following laminectomy, about 40 degrees. And then on the right, you can see our enduring result here, demonstrating a modest improvement in the sagittal profile.
So you didn't do any interbody reconstruction? Just posterior?
No, I mean, because in this case, there wasn't really an interbody. I mean, you can see that these are actually two vertebrae that are fused together from that area where he had the infection. And I mean, this is sort of, he has more bone. This CT doesn't do a good job at sort of showing, this is where I had drilled, sort of through the pedicles as part of the PSO. But I wasn't, we did that partially to decompress him, partially to correct him, but his bone, he was an older guy, his bone wasn't that great. So I wasn't trying to be a hero and correct him, too much. So this is part PSO, part defect, for there. And I think we threw some bone graft, into the little space that was in there. But the good news about infections, and granted, this wasn't really an active infection anymore, but the good news about infections is they tend to heal very well, which is exactly what happened to him in the first place, just, with a big spike of bone and in a kyphotic position.
Yeah, I mean, you did a great job with your technique, but I'm wondering the guys who do this regularly, Dr. Orlay or Dr. Chapman, whether they would have done this anteriorly and maybe needed a shorter posterior segment stabilization.
Great cases, great discussion. Oh, sorry, Vasa, you go first. Absolutely.
You can go. So I think it's a great case, a beautiful decompression. Obviously, as the was significant compression from the back, it was tight from the back. It would have gone a bit shorter, just to above to below. And probably once the compression is done, I would have stopped there and just stage my patient for enter cage afterwards to decrease the amount of manipulation of the cord. Sure. Especially neurologically involved. So once I've got the decompression perfectly clean, I don't try to reconstruct with the cage everything. If everything is perfectly clean, I stage it, and a few days later, a week later, I just put a cage in the front. But that's and I do, for this case, I definitely do a bilateral costal transversectomy. The less I touch the cord, the better my coronary arteries feel.
Sure.
Hey, Tim, what was the length of time from when you went in from when he had his initial decompression? And do you think that this complication could have been avoided if he had adequate treatment? Or what do you think the reason that he fell apart?
Yeah, it's difficult to, I think it's not entirely known, but, I think this would be a patient, that could have been considered upfront for a fusion. That might have been one thing that could have, helped against him developing this deformity. As far as the time, let's see, it was, we went
I
from,
think it said 5 months.
yeah.
But I think, I think for me, if I were doing this case from the beginning, this, we don't have a CT scan, but I mean, this looks pretty bad here. Like I would significantly worry that this is going to kyphose over because it's significantly eroded. So what I would do is probably go in, again, posteriorly, clean out the epidural component, do a fusion 2 levels up and down. And then I'd probably stick a piece of, allograft or something into this disc space, almost like a T-lift, like a thoracic T-lift, basically, in order to clean out the infection and get it to heal and provide some anterior column support.
I just got another question. So how easy was it you were working in the laminectomy bed? Or is it to do the decompression in the scar tissue?
I do this pretty often. I do these revision thoracic cases, once every couple months or so. And so, I guess I'm used to working around the scar tissue, and it's not as hard as you would think. You just take you just take a curette and you separate it from the side. Once you get down past the actual lamina and you're working, around the pedicles and you're working, ventral, then it's almost virgin territory at that point.
I wanted to just add one thing. So first of all, I think this is a very well done case. And I think it's very smart to not be dogmatically married to having to put in an anterior cage. If you can get a good decompression, you have a good realignment. And if you think that the anterior column is in reasonable continuity. So I think that's actually a very clever application. In the bigger picture, Rick Guy, I think you really hit it on the head. We really need, or we lack a risk score, such as like the SIN score for oncology for infection patients. This patient, in retrospect, at a pretty early time would have benefited from surgery. And again, stability plays a very significant role in successful treatment of infections, at least pyogenic infections. And that's just a big gap in our knowledge base right now, one that we're trying to actively change. But I think that the variables that you address are all very well handled. And again, the artistry of decompression equals the artistry of hardware placement. I always, personally, I find it almost more satisfying nowadays to have a very nice decompression accomplished without trauma to the neural element. So I congratulate you on that.
Thanks. I do want to try to get to this last case because I think it's the most interesting one. If we can do that, I don't know if maybe we can save some other questions for the end. So this is a very complex case, probably most complex case that I've done in my practice. So this woman initially presented about almost a year before I first saw her. She's 53. She had basically progressive back pain and lower extremity myelopathy, otherwise healthy, and she had this pathologic fracture, and she was treated by another surgeon. And he basically did a T3 to 7 fusion with a partial T5 corpectomy, didn't place a cage. They thought it was a tumor. PET-CT was negative, and the final pathology came back as chronic osteomyelitis. So she was treated with antibiotics. She returned a couple months later with worsening back pain and now had this image where she was developing a worsening kyphosis, and she had some cord compression. CT scan showed that the hardware, at least on the right side, was loose. So he took her back to the OR a couple weeks later, removed the right-sided hardware, did a wound washout and a revision laminectomy. This is all just based on the op note, and said that there was solid bridging bone with no movement, so left the left-sided hardware in place and closed her. After that, she continued to have pain. She continued to have wound healing issues. They treated her conservatively for another 4 months. And then she developed a worsening kyphosis. She was eventually lost to follow-up, and she showed up in my office, or she was eventually lost to follow-up in January of 2019. And then she showed up in my office in November of 2019. And so this was 13 months after her second operation. And she had severe pain. She was myelopathic in her lower extremities. She was pretty much full strength. She was walking with a cane, but she had normal bowel and bladder function, an unsteady gait. And she had a wound dehiscence in 2 separate areas with prominent hardware under her skin. And this is what she looked like in my office. So I admitted her through the ER from my clinic. This is actually, her wounds are packed, have packing in them. And this was her standing scoli films. And it's really hard to appreciate how bad her kyphosis is here, but she had screws pulling out on this side. 1 screw was left in the other side. And she basically has almost a 90-degree thoracic kyphosis with almost complete erosion, of her vertebrae here. And these are images a little bit off laterally to the facet joints. All of her screws were loose. And this is just giving you an idea of what her facet joints and pedicles, look like. These are just some other 3D reconstructions. This was her MRI scan. It was tough to get a perfectly mid-sagittal image, but her cord is clearly being stretched over this area of kyphosis with significant amount of signal change and thinning of her cord. So obviously the goal is the same as everything else: decompress her spinal cord, stabilize the spine, correct the deformity, and prevent future failure. But the question here was how, and that was, of course, the most challenging thing. So, I showed this to some of my partners, and basically what we ended up doing was we did this in a staged, operation. We staged it into 2 separate surgeries. So stage number 1 was, first of all, we positioned the patient, intubated her supine, and then used the Jackson table to sandwich her and flip her over. And we connected her with a Mayfield to the Jackson table using the special bed attachment that allows you to sort of manipulate the head. We removed all of her hardware. All of her screws were loose. We extended her laminectomies up. So we removed these lamina here and here in order to give her cord, as much room as possible. And then we basically removed all the facet joints also from here to here. We removed the pedicles from here to here, and we removed all of whatever vertebrae these were, which I think was more than 1. We removed them, and we basically did this and essentially completely disarticulated her spine in this region. But then we needed to do something to slowly and carefully correct her deformity. And the way that we did that, so this is the initial image just showing her in the supine position, pillows under her head because she was so kyphotic, attached to the Mayfield bed attachment, and then sandwiched in the Jackson table and then flipped. And then this was her initial wound. So obviously we enlisted plastic surgery to help us with that. These were the initial fluoro images. And then this is the image where there's essentially no bone in her spine connecting here to here circumferentially, and with the extended laminectomies now. And you could actually see when she would breathe, you would see this part of her spine separating from this part of her spine with her respirations. And thank God we had the ability to follow motors and sensories through this case, because that was at least something that reassured us that we weren't hurting her throughout this process. So after we were done, actually before we closed her, we were able to use the bed attachment to crank her head back in order to straighten her out. And this is essentially what we were able to get just by cranking. And you could actually see that space in her spine closing as we moved her. But this only gave us a partial correction. So what we did was we turned her over, and then we used traction, and we put her in about 50 pounds of traction. And we left her there for about a half an hour or so in the traction in order on her back to let gravity do its work. And we were able to get her from about 85 degrees to 54 degrees. And then we left her intubated in the ICU. We did the surgery on a Friday, so we left her intubated in the ICU in just 15 pounds of traction for over the weekend, and then took her back to the operating room on Monday. So this was a CT scan that we had, showing what we were able to accomplish by Sunday evening or so, showing the correction that we were able to get at that stage. So this is just showing what she looked like at the end of stage 1 and the beginning of stage 2, which I think we did get some extra movement just by leaving her supine and letting gravity do its work, over the weekend. Obviously, we were monitoring her neurologic exam throughout that course. So again, we flipped her back over using the Jackson table in Mayfield. We instrumented her from T1 to T10, which was of course complicated because her bone quality wasn't super great and she had already had instrumentation, which was loose at multiple levels. We placed an expandable corpectomy cage and then gradually expanding the cage and compressing, over the osteotomies as well as in situ bending the rods. We were able to get her from where we started at that case to this, and we locked her in place and then had plastics closed. This is what the final construct looked like. We added a rod just for some extra structural support. And then this is what she looked like at the beginning of that case and the end of that case, showing that we got, more correction. And this is her post-op x-rays. And that's her post-op CT scan, showing that we got her from that to that. And she is 2 years out now from surgery, completely neurologically intact with no pain, doing really well. So that's a case that I never hope I have to do again, but it was certainly a good, learning experience for me. And thankfully everything went well. Otherwise I wouldn't have presented it today.
Wow, what a great case. Unbelievable, Ken. Ken, let me ask you a question. Were you nervous the whole weekend with her spine basically being held intact with her cord laying in bed for 48 hours?
Yes.
Oh my God.
Yeah,
what a tremendous result.
Yeah, thanks.
That's beautiful result. Yeah, again, I agree. Once you started the correction on the first stage, do you have somebody to unscrub to manipulate the Mayfield just to get the head in extension or not?
So the way that this bed attachment, I don't know if a lot of other people use this bed attachment, but the way the bed attachment is it has a long screw that you can actually crank, and it will lift the Mayfield up very gradually. So yeah, we had someone unscrub and then just very gradually crank this.
You're talking about the C-flex? That's not the C-flex? No, it's different from the C-flex?
I think we call it the CMBU.
Okay.
But I don't know if it's the same thing or not. It's not the new robotic thing that they make.
For this kind of deformity, the cervicothoracic junction on the high, I've gone to put the patient in a halo traction suspension. I put the halo before, and instead of attachment, I get the suspension at 90 degrees of the head traction. This makes your surgery very stable. Once you want to correct it, you just grab the halo and you put the head the way you want. So you don't have to go with the Mayfield attachment, which is a little bit nerve-wracking when you have to get somebody to undo the Mayfield and crank the table. Control everything yourself with the system. You don't need to have anybody unscrub you just grab the halo, manipulate the head, and at the end of the case, when all the instrumentation is put in, you just remove the halo. So I find, and if you don't have it, you can use they do in New York, they at Columbia, you can use two Gardner well tongues with one attraction and one the suspension, and it's pretty stable. As a matter of fact, construct the head is pretty stable, and you can when the osteotomy is done, you can put the head any place you want.
Sure.
I find it just more useful than the classic Mayfield attachment, which is a bit nerve-wracking when the guy has to unscrub and manipulate you with your rod on one side. The other guy is pushing. You wonder if the head is going to fall or not.
Right.
I must say it's a great case. Great comments again. Dr. Singh asked a question, single stage versus multi-stage. I've done these cases with very severe deformities in the cervicothoracic junction, single stage. And I think the key things you addressed, however, I totally echo, and that is going very slow, having an extremely good release that includes the rib heads probably at 3 levels. So both sides have to have 3 costovertebral releases to get the rib cage that's scarred down and junked down fully off. I must confess also, I use the Mayfield, and I am the one who unscrubs, and I go under the table with the radiolucent Mayfield, and I'm the one who pushes it up. And I think that it's better that we had that mechanism also. And the mechanism tends to shorten the head back onto the shoulders. It kind of just crunches it down. Whereas if you hold it yourself and you do a very gentle distraction and then elevation, it allows you to really recontour the cervical-thoracic junction very harmoniously. One question, what flap did you use?
I think it was just the muscle. You mean flap?
The trapezius, the trapezius or the latissimus? Because this is a very common problem for us. We get a lot of these patients with these horrible cervical-thoracic wound breakdowns and hardware out there. And again, it's always something where I have not found an ideal flap, but our plastic surgeons usually use a trapezius flap if possible. But this looked like a little bit low for that.
Yeah, I don't, it was a couple of years ago, so I don't recall what he used.
Somebody also asked, what did you do between, as far as the wound closure, between the first and second stage?
I had the plastic surgeon completely close it as well.
Okay, so they closed after the first stage and then did the flap second stage.
Yes, yes.
The other thing, I actually, Jens, I do a bilateral costovertebral vasectomy at 3 on both sides to have very good control and the corpectomy. But the other thing too I do is once we get the halo or the Gardner-Well traction suspension, I did what she told me. I do a gradual correction of the kyphosis by changing rod. So I start with a very kyphotic rod, and then just go one side to right side. I start with 90-degree rod and on the right side, and then go to a 70-degree rod on the left side. Get me a little bit of correction. Then I go the 50-degree rod, just alternate back and forth, and get some either distraction if I see any kinking of the dura. And then with the head position, I can manipulate the head the way I want because it's in traction suspension. So plus the fact you change the rod, or you can use a flexible template. You know, the flexible template that helps you to measure the rod. You put it in on one side, and it's semi-rigid. That allows you to get some correction and avoid translation. That's another thing with the correction to avoid, because what's dangerous in this case is all of a sudden you get translation of your 2 segments, and you want to prevent this at all cost. So either one rod, just alternate one rod, right side, left side, a bit less bent each time, or you can use a flexible template, and that allows you to get some correction as well. Well, that's the way.
That was one thing that I forgot to mention, is that whenever I do, any sort of thoracic corpectomy or costotransversectomy, I'm always using a temporary rod on the opposite side that I'm working on, just to prevent, like you said, abnormal translation or movement.
Well, it's beautiful result. Okay, you should be congratulated. It's outstanding.
Thank you. Any other questions? I think it's 9 o'clock now.
Jack, do you want to take us out?
Yeah, sure. No, thank you very much. Ken, you did a great job. You can tell your orthopedic colleagues that you did a better job than they do. but it's always great from your university. Thank you so much. Everybody take care, stay safe, and we'll see you in a couple of weeks.
Thanks.
Thank you.
Good night, everyone.
Good night,
Good night.
everybody.
Thank you.